Good morning. I'm here to give a view from the front lines on EHR usability. I think what you're going to hear is going to be a validation of what Amy and Mohammed have described about the needs in the research and what's lacking on the front lines. I think the most important thing for most physicians in practice is clinical efficiency, speed in the workflows, and safety in patient care. And those, unfortunately, are elements that are not supported well by most of the EHR products that are on the market. During the last 4 to 5 years, during the incentive period that has started, vendors have had a lot of tasks on their hands, and most of that has been implementation and less so in research and development. Most of the research and development in terms of improving usability has been focused on getting their products certified with the meaningful use criteria and the certification criteria during the last 4 years. If you look at the market adoption figures, it's incredible when you look at anything else that's happened in healthcare during the last 5 decades and the pace of change, particularly with physician adoption of new information. Starting in the period at the beginning of 2011, if you look at the data from ONC that shows the hospital adoption, those that have registered saying that we have or we've contracted with an EHR vendor and plan to apply for incentives and submit, attest meaningful use data, the numbers went from under 15% in January of 2011 up to 93% of hospitals in the U.S. as in the 36-month period ending December 2013. And then among physician practices, less than 5% of physicians in the United States made themselves known as intending to attest in January of 2011. And at the end of last year, in a mere 36 months again, about 55% of physicians in the U.S. indicated their intent to attest. And I believe 43% or so had received incentives, or 37%. There was about a 15% gap between those that had received incentives and those that had applied. And on the hospital side, the gap was about 9%. So 85% of hospitals in the U.S. had received incentive dollars. How often do things change that fast in healthcare in the United States? So the vendors were very busy, but busy trying to help people implement and not necessarily to improve the products. When we look at the design of the products from the vendors and the configuration of those products by the customers and how short a time frame all this occurred, you can project that there would be some issues. In terms of design of the products, the intuitiveness of the products has been lacking in some of the most widely used products. And I'll give you some examples. These are some personal experiences and also experiences from colleagues that have talked with me about this. In the medication reconciliation screen, in one of the most widely used EHR products, both inpatient and outpatient in the U.S., you have to actually toggle out of that screen in order to see the start dates of the medication. So if I'm reconciling medications between the ambulatory and the inpatient environment, and there are 5 instances of a particular drug that are on this patient's medication list, most likely 3 of those are old medications that an end date was never put on by the user, or the medication was simply refilled, but no upkeep with the patient in terms of making sure that once a refill was done, you select the right medication to refill and delete the other ones that had maybe a dosage change. So if I see 3 medications that have the same dosage, one of those probably is not correct because the patient only brought in 1 bottle, but I can't figure out which one of those I need to say patient is not taking and which one they're taking unless I toggle out of that into a master med list. And most physicians won't do that. Another example, in terms of the problem list, updating the problem list typically is associated or integrated with order entry because you order an item that has a ICD-9 code, you need to, a CPT code, you need to have an ICD-9 code associated with billing purposes. But most physicians think in terms of doing a SOAP note with an assessment and plan. And in the assessment, you identify the diagnosis, and in the plan, you enter the diagnostics and therapeutics. And at that point, so you have your problems and your ordering in the documentation in that sequence. but the order entry screen typically is separated from the SOAP note documentation. Finally, most physicians in training, residents, are taught, and medical students, in fact, problem-oriented charting. Larry Weed's principles that have been around for decades. But with the leading electronic medical record systems, this seems to be an afterthought with multiple ways to configure problem-oriented charting. And the result is that if it is configured, it's typically difficult to configure, and most health systems end up not using it, or if they do configure it, it's configured in different ways, even within the same product at different sites. So when users that have privileges at multiple hospitals move across sites, they'll find that the way that the problem-oriented charting works in one facility is going to be different from that in another facility, even if it's the same software product. Now, another issue with the configuration and how that leads to usability issues is in terms of safety and alerts. For speed, most organizations have configured it to support a lot of dictation or speech recognition because physicians still struggle with structured data entry. Well, the loss of the structured data and using free text in the way most organizations configure their EMRs results in a lack of specific information to provide more granular alerting. So as a result, every outpatient, for example, triggers a requirement for DVT prophylaxis, even if it's a cataract procedure or something that is very minor and brief in nature. So the lack of the structured data in the requirement on the configuration side limits some of the enhancements on the alerting usability that have been designed in by some of the EMRs. Then we think about the outpatient and inpatient environment as well. There's a huge challenge for the vendors, which trickles down to the physicians. On the inpatient side, you obviously have many specialties, processes, and workflows, and the inpatient products have to support them all. On the outpatient side, you can be more focused. You have some vendors that are specifically for ophthalmology practices or for dermatology practices or surgical practices. And they're able to tailor the user interface more specifically for those specialties, and you may be able to see higher usability by those physicians of that specialty. But once you get on the inpatient side, that's off. Unless you're running an ambulatory surgical center that focuses specifically on orthopedics and joint replacements, you're not going to have that same level of usability that you might find in an outpatient specialized system when the physician is using the system in the hospital. And interestingly enough, you see that the vendor sizes seem to correlate with that. On the inpatient side, it is large organizations that employ typically hundreds, if not thousands, of people. And you look at the ambulatory side, and you'll find that some of the subspecialty EMR vendors have maybe 50 employees, and the research and development department is 30 people or even smaller in some cases. When I was at HIMSS earlier this year, or last month, I looked around at the products that were out on the marketplace and realized that there are some EMRs that are still running on mainframes. One of the leading inpatient EMRs still uses AS400s and green screen technology, although they've tried to put some overlays on top of this. But these vendors have over 100 hospital clients that are using their products. Very few of the EHR products have mobile native or web native user interfaces. They're designed on a client, mainframe or client server platform. The ones that do have mobile applications, and these are some of the large, widely used EHRs, use mobile apps mainly for viewing data. So you can make rounds and look up the patient's lab results and their radiology reports. But if you want to do documentation and order entry at the bedside on a mobile device, forget it. The web-native user interfaces are still in development. As I asked several of the vendors, particularly the large ones, they pretty much rely on Citrix for deployment of their applications. One large vendor who's among the top 3 in terms of hospitals that have attested using their product said that they are about 2 years away from a web-native user interface. Imagine that in 2014. So there's a lot of work that is necessary still on the vendor side, in our research and development community, in the academic community, and we hope for the better in the future from these products.